Very good evening, one and all. Very good evening, senior doctors, juniors, my peers, as well as very good evening, ladies and gentlemen. We all have joined here today for an academic feast that is to follow. As you all know, the ESH 2023 guidelines have just been out a few days back. And what we are to discuss right now is quick takeaways on what we can learn from the ESH and what we can implement here in our country. As each and every one of you know from the landmark ICMR InDive study that was just published less than a month back, we here in India have a huge burden of hypertension with a weighted prevalence of 35.5%. That's basically projected figures of more than 315 million patients of hypertension here in India. Also, as we all know from our clinical practice, challenges in hypertension in India are quite unique. There is a relatively early onset of hypertension in life. There is a trend towards a rural-urban divide, as shown by the latest studies too. There is a clustering of multiple CV risk factors, which is very typical to the Indian phenotype. Depending on where you are placed geographically or where you practice, there you might also see a seasonal variation in the blood pressure. Two other important things which are probably scary as a population is the rising average blood pressure of the general population, as well as the fact that many patients probably come up with early hypertension-mediated end organ damage, possibly, of course, due to poor control. To throw more light on the same, of course, we have an esteemed Indian panel and none other than Professor Giuseppe Mancia himself. I have the honor of introducing our esteemed moderator for the day. So can we full screen the slides? Yeah. Great. So we have as our esteemed moderator for the day, Professor Dr. Soumitra Kumar, who's senior consultant cardiologist at Fortis Hospital, as well as in certain other clinics in Kolkata. Next. We have as our esteemed speaker for the day, Professor Giuseppe Mancia, who is the Emeritus Professor of Medicine at University of Milano, the Director of Center of Epidemiology and Clinical Trials of the IRCSS, and the President of the ESH. Next. We have also Dr. Pankaj Vinod Jariwala, who would be joining us as an esteemed panelist, who's currently a senior consultant interventional cardiologist at the very reputed Yashoda Hospitals, and he also is a consultant cardiologist at Max Cure Medicity Hospitals, Hyderabad. Next. Last but not the least, we have Dr. Akhil Sharma, who is professor from the Department of Cardiology at KGMU, Lucknow, India. So on the same note, I hand over to our esteemed moderator for the day, Professor Soumitra Kumar. Over to you, sir.
Yeah, good afternoon from India. I think good evening from India and good afternoon Europe. So, Professor, a very hearty welcome to this webinar on the just concluded ESH highlights, especially concentrating on the latest guidelines on hypertension that have been presented there. And you being one of the pioneers in the field of hypertension, we have seen you presenting so many guidelines and practice-changing papers in the past. So it is really a privilege to have you in this webinar. So we are going to learn about the key takeaways and the key highlights of this recent guidelines on hypertension. The Indian burden of hypertension has already been highlighted by Dr. Parthasarathy. Apart from diabetes, we are progressively being known as the hypertension capital of the world as well. So it is very pertinent that we are going to learn from you about the various aspects of hypertension management as our practice has evolved. I was just flipping through the various facets of this new guideline, and I could see that almost no stone has been left unturned. There are, features on the various modalities of blood pressure measurement, including office blood pressure, home blood pressure, ambulatory blood pressure, and the various clinical subsets of hypertension management, the various subsets of heart failure, pregnancy, then stroke, and ischemic heart disease, and of course resistant hypertension. So we are really looking forward to hearing from you, Professor Mancia. So without further ado, I would request Professor Mancia to please present his slides and enrich us with his knowledge and presentation.
Okay, thank you very much. Can you see my first slide?
Not yet.
No, sir, no.
No. So I think I have to go back then, because I shared before, but
Yeah, you have to share it again, sir. Kindly share it again.
yeah, but how can I do that?
There is a green button on the bottom of your monitor. Would you see a green button at the bottom of your monitor?
No.
So it's similar to how you shared it the previous time. You just have to do it similar to what you did a few minutes ago.
Okay, wait a minute. Yes.
Yeah, okay, no problem.
Okay.
Perfect.
Okay. Now
Yeah.
ready. Okay.
Yeah, lovely.
Okay. Well, first of all, thank you, Mr. Chairman, for your kind words. It's a pleasure for me to be here and have a chance to present to quite a few distinguished colleagues the guidelines 2023 of the European Society of Hypertension, which were presented in Milan a few days ago at the meeting of the European Society of Hypertension. And you can find the document, not yet finalized because there are some corrections to be made, online in the Journal of Hypertension. And you can see this, there is an open access, so you can go to the text. Now you see here the title and the task force members' names. Guidelines is a rather extensive document. It addresses a number of comorbidities in addition to the main recommendations about treatment, and many aspects of the new guidelines have not been dealt with or addressed in previous guidelines, not only previous guidelines of the European Society of Hypertension, but also previous guidelines in general. But let me start from something which has not been changed, and it continues to be the same since the last 20 years. And this is the classification of blood pressure, which was proposed for the first time around 2003 by our American colleagues. And you can see that the classification goes from optimal blood pressure, less than 120/80 millimeter mercury, up to grade 3 hypertension, which is 180 and 110 millimeter mercury or more. I think this is a good and simple classification, and there is no need to change a clear classification to which physicians are used if this is still in line with the evidence. Now, it is customary and useful when dealing with hypertensive patients to also quantify or try to quantify total cardiovascular risk, because the level of cardiovascular risk is instrumental in many decisions about how to do with treatment. That is, how fast should blood pressure be controlled, how low should be target blood pressure, when to start drug treatment of hypertension, and even the type of drugs by which hypertension should be treated. Now, the European guidelines recommend to basically use a system which has been developed in Europe, the SCORE2 system, based on European data from Northern Europe and Southern Europe, because it is really well conducted. The study was well conducted. The number of subjects is extremely large, and the fact that it is used all over Europe, of course, allow a sort of standardization in the quantification of cardiovascular risk. But in the meantime, These methods to quantify cardiovascular risk have to deal mainly with a limited number of risk factors, because otherwise it would be too complex to show the algorithm, allow it to be used by physicians. And the score system is basically founded on sex, age, level of blood pressure, smoking, and non-HDL cholesterol. But the 2023 European guidelines emphasize that there are many other things to be considered by the physicians in order to have an idea of the clinical status of the patient. First of all, a number of previous cardiovascular events, established cardiovascular events, not only cardiovascular events, but also kidney disease. Then they are well-established, but also novel cardiovascular risk factors. And in this regard, the new guidelines have made a number of additions. For example, we can consider risk factor migration. Exposure. Sorry?
Yeah, put it up here.
Yes, can I continue?
Yes, sure, Professor. You can go ahead.
I can do that. But my video again, would it be?
Can I request the host please mute all others, my attendees and the webinar? Yes, Professor Mencia, please go ahead.
Okay, it's, for example, new risk factors are air pollution, noise, frailty, psychosocial and socio-economic factors. So just to give some examples, uric acid, even the little LP, and these are mentioned in the guidelines. They cannot be translated into algorithm because it would be too complex, but it's something the physician has to ask and take note in order to have a full idea of what is clinical condition of the patient. And this includes also heart rate, which is a clear-cut cardiovascular risk factor. And also, it is important for the physician to collect information on additional clinical conditions or comorbidities, for example, gout. Even non-alcoholic fatty liver recently in several studies have been indicated as a condition that can give an idea of the clinical status of the hypertensive patient. Not to mention, for example, depression, migraine, or even erectile dysfunction, which could, of course, give the physician an idea of whether there is an alteration of the endothelial system secreting nitric oxide. But what has been always a hallmark of the European guidelines has been the strong recommendation to consider the so-called asymptomatic hypertension-dependent organ damage. Because this is very common in the hypertensive population. These are data from a population study, the Pamela study, which were running in the northeast outskirts of Milan, in the general population. And please notice that among hypertensive patients, more than 40% had evidence of asymptomatic cardiac damage, such as left ventricular hypertrophy, or reduction in renal function below 60 ml a minute. So it's something very common, and it is mandatory in hypertensive patients to try to have an idea of whether the patients have asymptomatic organ damage and how many organs may be involved. And here you have a list of all the new measures of asymptomatic organ damage which can be used. Some of them has to be used routinely, for example, an electrocardiogram, urine albumin creatinine excretion, calculation of glomerular filtration rates and serum creatinine. Some others, of course, assessment depend on the healthcare conditions in which the physician operates, but you can see that there are quite a few more sophisticated measures of organ damage, which in several countries can be used, at least some of them, and some are quite new. For example, microvascular assessment at the level of the retina via computerized analysis, which can give an idea of the status of the arterioles, which are early affected by hypertension. And this is a figure which is provided by the European guidelines, in which you have a list of the measurements which can be considered for assessment of organ damage and hypertension. What I would like to show you and mention, but then you have to go and look at the figure, is that in this figure, what you can see is how sensitive are these measures to changes induced by treatment. Some of them are quite sensitive, such as, for example, alterations in protein excretion in the urine. Some others, they are not so sensitive, for example, left ventricular hypertrophy by echocardiogram. Then the time to change. Some system, it takes only few hours for the change, but some other system, there is no point in repeating the examination within the first 3 months or 6 months because the changes are quite slow to develop. And finally, at the extreme right, you see that there is evidence today of whether reduction in organ damage by antihypertensive treatment is associated with evidence of reduced cardiovascular events or renal events. That is, whether reduction in organ damage is a marker of patient protection. And you can see that now we have data that this is the case. For example, for regression of left ventricular hypertrophy, for decline of glomerular filtration rate, for reduction in proteinuria, and so on and so forth. Now, this is quite important in the follow-up of the patient because if a regression is found, this means that the doctor is protecting the patient by the treatment he or she has selected. And this is just an overall description of the approach based on calculation of risk factors, assessment of risk factors, and assessment of organ damage. You can see a classification in hypertension which complements the classification based on blood pressure values. This is based, this classification, on how many risk factors are associated with hypertension, presence or absence of organ damage, and established cardiovascular disease. And you can see that, of course, the higher is the blood pressure, the higher is the cardiovascular risk. But if there are other risk factors, organ damage, or established diseases, well, you can have a condition of high risk even with the modest reduction in blood pressure, or even a blood pressure in the high normal range. If patients had in their history an event, cardiac event or renal event, well, you can see that the risk is very high, even if blood pressure is not above 140/90 millimeter of mercury. This has been shown by all European guidelines since their beginning, and with modifications, of course, associated with the progression of knowledge. Then one session, important session, is on blood pressure measurements. And there is a strong statement here. That is that the most important blood pressure to deal with hypertension is office blood pressure. So don't be sidetracked by the important data associated with out-of-office blood pressure measurement. Office blood pressure remains the most important blood pressure because, as you can read in the first 3 lines, all information we have on risk factors and on protection by treatment in the context of randomized clinical trials, well, this has been obtained by office blood pressure, not by out-of-office blood pressure. And the level of evidence for this is the maximal one, that is 1A. So office blood pressure is the important blood pressure to consider. And guidelines provide a figure that summarizes how office blood pressure should be measured into details. And this is, of course, something extremely important. You should measure blood pressure well to avoid errors that can lead to over-treatment of patients or under-treatment of patients. How often should we measure blood pressure in the population? This is not easy to be done, but the suggestion by the European guidelines is that blood pressure should be regularly measured after 40 years of age. And we should take also advantage of opportunistic visits. Anytime there is a visit, either for other medical reasons, I think doctors should measure blood pressure and report the values somewhere in the patient's information sheet. Now, we know that there are other measures of measuring blood pressure in addition to office blood pressure, and in the last 30 years, there have been huge number of papers on different measures of measuring blood pressure: unattended blood pressure during exercise, central blood pressure. Now, these blood pressures are somewhat criticized by the guidelines. They are interesting, but still matter for research and not matter for clinical practice. And in some cases, such as, for example, unattended office blood pressure, in which the patient is left alone in a room, there are logistical difficulties, because, of course, we need to have separate rooms for individual patients, and this can be a logistic difficulty in several countries by most physicians. Of course, the most important blood pressure to consider are, as our chairman mentioned, out-of-office blood pressure, ambulatory blood pressure, and home blood pressure. And these are reported and described in detail. Home blood pressure has a better reproducibility and prognostic value than office blood pressure. It can allow to identify some phenotypes, quite interesting phenotypes, such as white coat hypertension and masked hypertension. And home blood pressure can be considered as a blood pressure to be used in the long term because it improves adherence to treatment. There are several data on this, and also can give a doctor an idea of how often he or she should see the patient, because of course, if blood pressure is well controlled, then visits can be somewhat rarefied, but if blood pressure is not controlled, then of course you should visit the patient again. Now, more or less the same thing are said for ambulatory blood pressure: better reproducibility, better prognostic value on events than office blood pressure. It is important to confirm the diagnosis of resistant hypertension, but it should be measured in a proper way to avoid hours without values during the 24 hours. And the suggestion of the European guidelines is to measure blood pressure every 20 minutes, so 3 measurements per hour throughout the day and night. So what is said in the end about use of out-of-office blood pressure is that it provides important information in both untreated and treated patients. And so it should be considered by the physician whenever possible. Now you may say, what does it mean? Well, it means that although everybody agrees that these 2 ways of measuring blood pressure are important, they lack an essential type of information. There is no randomized clinical trials which has investigated whether guiding treatment by ambulatory blood pressure has an advantage over guiding treatment by office blood pressure. All trials we have so far are based on office blood pressure. And this is a tremendous limitation, if you think. It's almost a shame that in the last 30 years, no trial has explored this important point. We only have observational studies with ambulatory or home blood pressure, in which ambulatory home blood pressure was measured only once, and this is also an element of weakness. And you can see that this, of course, is a limitation in deciding at which level of blood pressure we should start to give antihypertensive drugs to our patient. That is, when should we start treating our patients with antihypertensive drugs? Now, these are epidemiological data for more than 1 million patients, and they show what you know very well. That is, the higher is the blood pressure, the greater is the incidence of cardiovascular events, both cerebrovascular events, coronary events, heart failure, and so forth. And this is the case at all ages, even in patients aged more than 80 years. The higher is the blood pressure, the greater is the cardiovascular risk. Now, can we have an idea of when to start antihypertensive drug treatment by these data? Obviously not, because the relationship between blood pressure and events is continuous. There is no threshold that doctors can use. But the threshold comes from another way of reasoning. That is the threshold at which a physician should decide to start treatment is that provided by the randomized clinical trial data. That is the threshold above which reduction in blood pressure by treatment is associated with patient protection. That is the entry blood pressure values used by trials. And this has been the criterion selected by the European guidelines, but also by other guidelines. That is, doctors should consider using antihypertensive drugs whenever systolic blood pressure is equal or above 140 millimeter of mercury, or diastolic blood pressure is equal or above 90 millimeter of mercury. And you can see that the level of evidence is maximal because we have huge number of trials and patients showing this. I think more than 500,000 patients. This confirms previous recommendations. There is no element of novelty in this. Now, there is one exception to this, however, at least two exceptions. First of all, in frail patients who have never been included in trials, we really do not know at which level to start a drug treatment. So treatment is individualized, responsibility goes to the doctor. Guidelines cannot help because there are no data. The second thing is there is one condition in which treatment should start below the level of 140/90 millimeter of mercury. If patients have in their history a cardiovascular event, mainly myocardial infarction, but also cerebrovascular event, then there is evidence that if we start treatment when they have a blood pressure, say 135 millimeter of mercury systolic, reducing blood pressure is protective. So, for these patients, threshold for treatment is not equal or above 140/90, but equal or above 130/85 millimeter of mercury. Now, this goes for the general hypertensive population. Then the guidelines consider specific conditions in which threshold for treatment can be different. For example, one of these conditions is patients above 80 years of age. Below 80 years of age, from 18 years to 79 years, threshold for treatment is indeed 140/90 millimeter of mercury. But 80 years of age or above, then we have to be more conservative because the only trial we have recruited patients having a systolic blood pressure of 160 millimeter of mercury. So the threshold strongly based on evidence in octogenarians is 160 millimeter of mercury. But recent studies have shown that even in patients ranging with blood pressure at the beginning in 140/159 millimeter of mercury, there is evidence of protection, although weaker evidence than the previous one. So guidelines recommend that the first goal should be to start treatment at 160 millimeter of mercury, but then physicians should also consider the possibility of starting treatment when blood pressure is in the lower range, that is 140/159 millimeter of mercury. And this is true also for isolated systolic hypertension. Evidence from dedicated trials tell us to start treatment at 160 millimeter of mercury or above. But recent data and meta-analysis of subgroups from randomized trials tell us that physicians should also consider the possibility of starting treatment at lower values, that is between 140 and 159 millimeter of mercury. And the evidence is lower, is 1B, not 1A. Now, I'm sure that you are wondering, what can we do with ambulatory and home blood pressure? They have nothing to do with our decision when to start the treatment. Well, remember, there are no trials with these blood pressure values. And we thought that the best thing we could do to upgrade the use of ambulatory or home blood pressure would be to say, do it whenever it's possible. But they, of course, cannot help us as far as values are concerned because there are no direct data on this. The only data available are the corresponding values, that is the ambulatory blood pressure values corresponding to 140 over 90 millimeter mercury, which is 130 over 80 for 24-hour blood pressure, and 135 over 85 for home blood pressure. Remember, these are indirect data, not direct data. And in addition, guidelines make a statement here that there is a limited relationship between office and out-of-office blood pressure. And this means that the average values, as you have seen before, I mean, individual patients can have differences that depart from these average differences. So please use these data, but once more, remember that the best evidence we have is still related to office blood pressure. The other data, they increase our information on the patient, but not for this important aspect. How low we should go with blood pressure? Again, office blood pressure is the blood pressure by which we have to consider target blood pressure value or goal blood pressure value. And here the data are difficult to be interpreted. There is a section of the guidelines called challenge in the decision of target blood pressure value. And that's because some of the studies have limitations that make our understanding difficult. For example, the SPRINT study, lower blood pressure close to 120 millimeter mercury systolic. And this was associated with protection. But the way they measure blood pressure in SPRINT, well, it obtains data which are lower than the classical data from the standard way of measuring blood pressure, because blood pressure was measured in unattended patients. Attended patients had the so-called white coat effect. In this study, for example, in which you used beat-to-beat ambulatory blood pressure, attended blood pressure measurements were associated with an increase in blood pressure, unattended by a reduction in blood pressure, because patients were alone in a silent room and so forth. And the difference is quite marked, more than 10 millimeter mercury, even 15 millimeter mercury. So the 120 millimeter mercury by unattended blood pressure may correspond to 130, 135 millimeter mercury, even more in the classical blood pressure measurements. So this helps us to a limited degree. Then there has been a recent study, and this is the STEP study in elderly patients above 60 years of age. And in this patient, the intensively treated group had a blood pressure reduction below 130 millimeter mercury. And this was associated with reduction of cardiovascular events. Now, the problem with this study, the STEP study, is that the control group included hypertensive patients. So the difference between, in events between patients in which blood pressure was reduced below 140 and patients in which it was reduced below 130, well, it's a comparison not only of hypertension, it includes patients with blood pressure values above the normality range, and this could have amplified, in a way, the difference. But despite this, I think all meta-analysis of randomized trials, about 300,000 people, so very large meta-analysis, they show that if blood pressure is reduced below 130 millimeter mercury, compared to above 130, between 130 and 140 millimeter mercury, or it is reduced below 80 millimeter mercury compared to 80 to 90 millimeter mercury, well, you can see that there is an incremental protection, a further reduction in cardiovascular events. So, for this reason, and after discussing this matter in the text, we came to the conclusion that target blood pressure value should range between 140 and 120 millimeters of mercury systolic, and always about 80 millimeter of mercury, between 80 and 70 millimeter of mercury. In most patients, the first goal is to go below 140 and above 130, because at this level, there is already quite a large protection of the patient. If treatment is well tolerated, then in most patients, you should try to go between 130 and 120 millimeter of mercury. Never try to go below 120 over 70 millimeter of mercury, because this can be associated with a large number of side effects and increased risk of cardiovascular events. This applies to the general hypertensive population, but of course in medicine you never have a recommendation that holds for all patients. In people above 80 years of age, target blood pressure is more conservative. First goal is to go below between 140 and 150 millimeter of mercury. If treatment is well tolerated, then try to go between 139 and 130, but never go below 120, 130 millimeter of mercury. So you see that we are a step higher here. And this is true also for isolated systolic hypertension. First goal is to go between 140 and 150. This is a must. Second goal, if treatment is well tolerated and you don't capture signs of underperfusion of vital organs, then try to go between 130 and 139 millimeter mercury. For diastolic blood pressure is simple. Everybody should try to go below 80 millimeter mercury, but remain above 70 millimeter mercury. Consider that if you are too aggressive, patients experience side effects, and sometimes there are side effects leading to treatment discontinuation. You see in this large meta-analysis that the greater is the blood pressure reduction, the greater almost exponentially is the number of patients abandoning treatment because of side effects. And abandoning treatment means to put them at a much greater risk of having an event. How to treat hypertensive patients? Well, you see that it is mandatory for any grade of blood pressure, from grade 1 to grade 3, you should try to establish non-pharmacological treatment. And you know what is the pharmacological treatment, and it's proper diet, no smoking, exercise, no alcohol consumption, and things like this. So they have the ability to lower blood pressure by few millimeter mercury, but of course this can help. The problem with non-pharmacological treatment, lifestyle changes, is that adherence to this type of intervention is extremely limited, unfortunately. So lifestyle changes apply to every patient. Then if patients have a severe hypertension, grade 2 and 3, or have grade 1 hypertension, but a high cardiovascular risk because of associated risk factor or organ damage, then you should implement drug treatment simultaneously with the lifestyle intervention, that is, immediately. If patients have grade 1 hypertension, but a low cardiovascular risk, that is only hypertension, not other risk, no dyslipidemia, no diabetes, and so forth, then you can try to control blood pressure only by lifestyle intervention, say for 3 months, 4 months, 6 months, depending on how you deal with the patient, I mean, how reliable is the patient and so forth. But if at the end of this period, blood pressure is not controlled, then it is mandatory to add to lifestyle changes also drug treatment. But you have this period in which you can avoid treatment and try to control blood pressure only without drugs. Which drugs should be used? And this is the new figure by the European guidelines. Now you can see that we have basically 5 drug classes. ACE inhibitors, angiotensin receptor antagonists, diuretics, calcium channel blockers, and also beta blockers. And the novelty of the European guidelines is the re-upgrading of beta blockers and put them at the same level of the other drugs. Because if you look at the evidence, beta blockers have the ability to lower blood pressure. They have a lot of evidence of protection in randomized placebo-controlled trials. And in comparison trials, more or less, they show the same ability to reduce mortality as other drugs. So we go back to 5 drug classes as the basis, the fundamental drugs for the treatment of hypertension. And you can see that these drugs can be used together for combination treatment. This is what the message of the figure is. Of course, there are several other, the importance of beta blockers goes also beyond this, because beta blockers have a number of specific conditions, which have been mentioned also by previous guidelines and very well known to all of you. Chronic coronary syndromes, post-myocardial infarction, heart failure, atrial fibrillation, and even non-cardiovascular conditions, such, for example, women with childbearing potential or planning pregnancy, disorders in pregnancy. These are conditions in which beta blockers have a very important part in the treatment strategy. And you see in how many other conditions this has been considered by the guidelines. Beta blockers are preferred drugs. Tachycardic patients, patients with migraine, essential tremor, anxiety, psychiatric disorder, hyperparathyroidism, glaucoma. In a paper we published not so long ago, we counted about 50 conditions, even non-cardiovascular type of conditions, in which beta blockers are commonly used as preferred drugs. But in addition to this, of course, we have to consider other drugs, not as for the primary treatment of hypertension, but in some conditions in which treatment can be difficult with the previous drugs. And here they are listed: steroidal mineralocorticoid antagonist, loop diuretic, alpha-1 blockers, central agents, vasodilators, and even very new drugs which are considered for particular conditions in diabetes, for example, in heart failure, ARNI, SGLT2 drugs, non-steroidal mineralocorticoid receptor antagonists such as finerenone. And these drugs have shown the ability to protect the kidney and the heart in the case of SGLT2 drugs, also non-diabetic patients. So probably in the future, we will see a progressively greater use of these drugs. Now, how should these drugs be used in terms of treatment strategies? Well, guidelines continue to strongly support initial combination treatment of 2 drugs. You can see this here in the right upper part. And what they say is that we should start in most patients with 2 drugs, lower dose, increase the dose if there is no satisfactory response, try to use 2 drugs in a single pill combination, because there is evidence that simplification of treatment improves adherence to treatment, and go to triple therapy if 2 drugs are not enough. And this is the algorithm. Now, combination treatment of blockers of the renin-angiotensin system with calcium channel blockers or a diuretic, lower dose first and full dose later, are still recommended. Go to triple combination if 2 drugs are not enough. Use beta blockers at any treatment step whenever there is a specific condition, and there are indeed many specific conditions in which beta blockers have to be used. And try, whenever possible, to use combination treatment as a single pill because of the effect on adherence. Please notice that if the drugs dosing is correct, and the drugs used work through different mechanisms, for example, a blocker of the renin-angiotensin system, a calcium channel blocker, and a diuretic, or even a beta blocker, well, you can control more than 90% of the hypertensive population. 5% surely have the so-called resistant hypertension. And this is difficult. And sometimes the best advice which can be given to the doctor is to consult a hypertension specialist or send the patient to a hypertension center because, of course, diagnostic ability of hypertension center and identification of secondary hypertension, low adherence to treatment, and things involved in resistant hypertension, of course, the potential of these centers is much greater than those of the practicing physician. And this is the algorithm of resistant hypertension. When you see a patient with resistant hypertension, please call it apparent resistant hypertension. Then you have to do a lot of diagnostic maneuvers to see whether this is not due to low adherence to treatment, is not due to secondary hypertension, and it's not apparent because ambulatory or home blood pressure are normal, particularly ambulatory blood pressure are normal. So resistant hypertension should have an elevated ambulatory blood pressure as well. And if you consider this, only 5% of the patients have resistant hypertension. Now, 5% seems to be a small number, but we have million hypertensive patients. So even 5% means 100,000 patients. And here, treatment is a bit complicated. This is why, of course, having the help of experts in hypertension can be useful. We already have 3 drugs. The 4th drug, the preferred drug, should be spironolactone, a mineralocorticoid receptor antagonist. But there are also other drugs, because sometimes spironolactone can lead to serious side effects and can be given only when renal function is above 30 ml per minute of glomerular filtration rate. So not in patients with renal insufficiency. And the other drugs you may consider are beta blockers, alpha-1 blocker, centrally acting drugs. In patients with renal insufficiency, you cannot use spironolactone, but interestingly enough, there's been recent evidence that chlortalidone, despite being a thiazide-like diuretic, have shown the ability to lower blood pressure in patients with renal insufficiency. The other types of treatment are those I mentioned before. If all of this fails, then there is now evidence that renal denervation can lower blood pressure on the top of antihypertensive treatment. So you can propose to the patient explaining what it means to perform renal denervation, which has been, of course, validated by a number, 5 or 6 randomized clinical trials. And this, as you can see, is mentioned by the guidelines. You see a level of evidence which is not high for one simple reason. Blood pressure is very well demonstrated. Blood pressure reduction is very well demonstrated. But what has not been demonstrated, because there are no trials, is that this reduction is associated with a reduction of cardiovascular events. There are not yet any study on this important point. Then, of course, this is the general concept. Then the guidelines go into specific situations. There is one part of the guidelines telling us how to diagnose and treat different hypertension phenotype, white coat hypertension, masked hypertension, isolated systolic hypertension in young people, isolated systolic hypertension in older people, isolated diastolic hypertension. There are young people in which there is only an elevation of diastolic blood pressure, nighttime pattern, and so forth. I have, unfortunately, no time to go into detail here. And then there are a number of conditions in which diagnostic aspects and treatment aspects are described, more than those I listed here. And this makes the document, the guidelines, the recent guidelines, the European guidelines, a rather comprehensive document. And I will move to the final part. For the first time, guidelines give a lot of importance and space to follow-up of the patients, because follow-up is important. If follow-up is deficitary, well, then we cannot hope to maintain blood pressure control. And you can see how many things are discussed in this part. The problem of non-adherence to treatment, the problem of therapeutic inertia, how to empower the patient, associate the patient to the reasoning about which treatment and how to deal with hypertension. And then the future use of telemedicine, role of pharmacies and team-based care, role of hypertension clinics or hypertension centers, and so forth. I've no possibility to discuss this. I can only say that several recommendations in this line are not based on evidence. There are not too many studies. They are based on common sense in a way and consensus by experts. So what I can say to summarize this is that in the first 3 months in which up titration of treatment is decided, is done, you have to see the patient very often, every 2 weeks at least, to titrate up treatment until blood pressure is controlled. And remember that in high-risk people, control has to be achieved as fast as possible, because those in which treatment is too slow, well, the risk increases. After 3 months, you have another important period between 3 months and 1 year, in which you have to be sure that blood pressure control is maintained. And here the suggestion is to see the patient every 3 months at least. If you are sure that blood pressure is controlled and you have, for example, also home blood pressure measurements, after 1 year, you can rarefy the visits. For example, every year. You shouldn't abandon the patient. In previous guidelines, it was said every 5 years. No, you lose control of the patient. The patient-physician relationship goes to pieces. So even if visits are rarefied, you should plan to see the patients at least once a year. And of course, depending on the severity of the patients and the reliability of the patient tale to you, well, you have also to plan for examinations, laboratory examinations, measurements of organ damage, and so forth. Not too often, but at least every 2 or 3 years. Finally, guidelines also give an idea of how much work remains to be done, the so-called gaps in evidence at the level of epidemiology and risk, at the level of the diagnostic procedure, at the level of treatment, and at the level of the follow-up. And this is work for the future. Thank you very much for your attention.
Thank you very much, Professor Manshia. Very clean, crystal clear points for the audience. I now open the session to our moderator and esteemed panelists for an honest discussion with you. Dr. Soumitra Kumar, over to you. We believe Dr. Kumar is having some network issues. In such a scenario, Professor Jariwala, would there be any questions you would want to ask?
Yeah, that is very good, wonderful talk by Dr. Manshia, and I think you have done a wonderful overview of the management of hypertension, and you covered every corner of the hypertension, including newer drug medications, and also I was very glad to see that you spoke on renal denervation therapy also. And I think my question is, in India, we get a lot of patients of resistant hypertension these days. And despite of giving 2 drugs, 3 drugs, actually I have many patients which are on 5, 6 medications also. And sometimes we have given medications which are not recommended. Like I have given drugs like peripheral alpha blockers and even centrally acting alpha blockers also. And sometimes we don't see any control of blood pressures in this group of patients. And we are now in India, we have a lot of triple drug combinations are also available for the improvement of the compliance. The problem is number of drugs increases, the patient comes down. Patient doesn't want so many medications to be given when we prescribe them. So maintaining them for such a long period of time with so many multiple drugs, it becomes very, very difficult to continue them. And what is your experience on that triple drug combinations and giving so many medications for the management of blood pressure, and how do you monitor them on regular basis in your outpatient department?
Yes. Well, I don't want to look too optimistic about this, because of course what you say is absolutely true. We of course we discuss the success when there is success, but it is of course true that in some patients, no matter what you do, I mean, blood pressure cannot be controlled. One aspect you mentioned, which is true, I mean, these patients should continue to be followed regardless whether blood pressure is controlled or not by expert hypertensiologists, I mean, and seen. I can only say that, of course, you have to go up with drugs as much as possible. Some of the new drugs may help because new drugs can help in lowering blood pressure. For example, the SGLT2 drugs lower blood pressure, and they seem to be active also in non-diabetic patients. So I expect the future to be these drugs to become part of the treatment. But it is true that no matter which we do at the present stage, some patients will not achieve control. One thing I can say, however, don't think that if you don't achieve control, which is placed at less than 140/90, I'm not talking about less than 130/80, less than 140/90, don't think that you have failed, because patients is anyway protected by the reduction in blood pressure. Maybe it could be protected more by lowering blood pressure, but going from 160 to 140, you reduce the greatest amount of hypertension-related complications. Okay, so this is already an achievement. I think sometimes we forget to say that we place the target at less than 130, but if your patient remains at 132, doesn't mean that you have not achieved an important goal.
Yeah, actually, we see a lot of cases of white-collar hypertension, where in the office we see often the blood pressure is 160, 170, like that. So usually I rely on home monitoring of blood pressure. So usually I encourage ambulatory blood pressure monitoring or home blood pressure monitoring, and surprisingly I found that their home monitoring blood pressure is very much normal. They come and tell me blood pressure in the home.
This means that the risk is this means that the risk is less. We still do not know whether in this called apparent resistant hypertension, because out of office blood pressure is normal, the risk is remains a little bit higher anyway, but certainly less than in patients with both in and out of office blood pressure elevation. So this is also a good thing to do. I mean, you should continue to monitor not only once at the beginning, but monitor out of office blood pressure. If you have most of the evidence is on ambulatory blood pressure in resistant hypertension, to be fair. We also mention home to facilitate the task of the physician. But the confirmation of the diagnosis, strictly speaking, is based on ambulatory. But I think I would say that the recommendation, what the guidelines wrote, that is, if ambulatory is not available, then go to home blood pressure is wise.
Professor Mancia,
yes,
if I'm not mistaken, you mentioned that regular measurement of blood pressure should start beyond 40 years of age. Now, in India, everything is precautious. The onset of hypertension, coronary artery disease. So we find a lot of patients in their 30s even.
I lost your voice.
Would you think that 40 years? I like to hear.
I like this. I like your question. I think 40 could be too conservative, because. But you see, there is a problem there. There is a section in the guidelines dedicated to young patients. And the problem is that evidence of the benefit of treatment in young patients is just not available. Because it is true that entry criteria in randomized trials, they can recruit patients from 18 years of age up to whatever. But since trials are based on generation of events, they mainly recruit middle-aged or elderly patients. So because of the choice of having event-based trials, we do not have evidence of what treatment does in young patients. We have to extrapolate data from all the patients, and of course the extrapolation is it is likely the treatment is protective in young patients like in old patients. This is the basis for our medical practice in a way. Recently, there have been real-world data, quite interesting data, because no trials in young patients, okay? But real-world data based on 100,000 patients, young patients followed for 10 years. Initial age was between 30 and 35. So I think it's relevant to your question, to your comment. And they showed that in these patients, those with the blood pressure elevation had an increase in cardiovascular events. So hypertension, no question, is a risk factor also for young patients. What we do not have is a measure of the benefit of treating young patients.
Can I have some opinion? Yeah, please carry on.
Also because in young patients, we treat these patients not so much to prevent a myocardial infarction. Between 30 and 35, you can have a high blood pressure. It is almost exceptional to have a stroke or myocardial infarction. We treat these patients to prevent progression of asymptomatic organ damage, which can lead to an event maybe 20 years later.
Unfortunately, we have a lot of patients presenting with MI and even stroke in their 30s and early 40s. I would like to hear from Dr. Akhil also. Professor Akhil, would you like to comment on this? So what should we do with young patients in India?
Definitely, sir. First of all, very much thank you, Professor Mancia, for your immense presentation and very quick review of the latest guideline. And definitely, sir, as in India, we all are aware that we did some cross-sectional studies, and even in the 20s, we found about the 10 to 20% of the patients with hypertension. Definitely, again, the question, if we decrease the age of the screening in our countries, it's again a huge burden on our health system. But definitely, as we are on higher risk, at least for 10 years before in Western world. So I'm very much interested that the screening age in India should be lower than what in Western world. And recently, in last decade, we are seeing the cardiovascular disease and even in MI in very significant proportion of patients in their 20s and or their 30s. So I think it's maybe a different epidemiological or I can say the
demographic
characteristics, and we have to develop our standard or guideline, and we can down the age of the screening up to 20 or I can say the 18 years.
Professor Mancia,
let me clarify what I mean. Of course, you can find people 30 years old with myocardial infarction. And in India, with a population of more than 1 billion people, I mean, of course, there are many cases. But I'm talking about what you can do with randomized clinical trials. I mean, if you have a randomized clinical trials and you base your data on people around 30 years of age, you need a gigantic randomized clinical trials to get the statistical power. And this is impossible to be done, if nothing else, because of cost. Or you need a long follow-up, 10, 20 years, but the trial can have a maximum follow-up is 5 years, maybe 6 years, no more than this for logistical reasons. This is why we do not have data from randomized trials. And in the future, I hope we will have data from other approaches, which could be real-life approaches. And India could be the ideal place to do this because the population is young.
Yeah.
Yes.
Thank you.
We get your point, sir.
Professor Mancia, a wonderful statement made by you. And even just to add on to what Dr. Akhil, Professor Soumitra Kumar all just mentioned, So traditionally here in India, we have patients tend to develop CV disease more than a decade before than of our Caucasian counterparts. Even if you look at the incidence of heart failure, average heart failure admissions in India are at the age of 53 versus 70 where it's in the West. Incidence of type 2 diabetes, unlike conventional medical college teaching, which always earlier taught us that, once a patient is hypertensive at an age less than 40, secondary hypertension should be ruled out. No, a lot of patients in India tend to have essential hypertension at a much younger age, as Dr. Akhil just said. And the same holds true even for type 2 diabetes. We are a country who have young type 2 diabetic populations, wherein in maybe the Western world you would have a LADA or a type 1 diabetic patient at that age. So these are the challenges. So a quick question from my end based on what you presented. I believe the ESH 2018 guidelines were probably the first to say how low one can go, the 120/70 perspective. Professor Soumitra Kumar can also add to that. Were the first guidelines probably to say how low one can go, 120/70.
Yeah.
And an addition takeaway that we understand from the ISH guidelines too, which were probably taken in the ESH, was to achieve control within 3 months. Try to achieve control within 3 months. So this is where a question can, we would love to hear from you. How frequently, once you start antihypertensive therapy, to achieve that level of control within 3 months, how frequently should a patient ideally be followed up in this time, within the first 3 months? Your takes.
Of course, as I mentioned, this is there is no trial saying 3 months, 4 months, 2 months is ideal. So in fact, the level of evidence is low there, of course. It is a consensus mode. But it seemed to us to be a reasonable time interval within which the patient can be seen 3 or 4 times, perhaps even more, maybe. And so there is time for the doctor to up-titrate drugs, and even side effects can develop, and so give information to the doctor. But this is only orientative. Don't take it as a must because of the low level of evidence, and the remaining number of visits in follow-up also have this limitation. I mean, nobody tells us, every 3 months is better, is worse. I mean, you should have every 2 months or every 6 months. Sure. There are some data showing that, those seen 3 times did better than those seen 2 times only. But you can find anything in the literature if you search extensively. So these are, but I think something which is probably appropriate for the guidelines is to discuss the follow-up issue, while in previous guidelines, follow-up was restricted to maybe a couple of pages. Because of the lack of evidence, but this is perhaps the most important part of management of hypertension. Because of adherence, now we do have the problem of adherence, and people understand what it means, non-adherence. And so there is also a description of the possibilities to assess adherence, which unfortunately are not good. Because if you inquire with the patient, a colleague of mine, expert in adherence, is used to say, well, it's waste of time. You're better to toss the coin rather than asking the patient. Maybe it's too much, but anyway. And then, for example, even expensive measurements of the concentration of the drug in the urine or in the blood for resistant hypertension, for example, if you think have a limited value, because adherence is a very dynamic phenomenon. A patient can be adherent, fully adherent for weeks, and then no adherent at all. So you have to have a long-term estimation of adherence. Now, this is possible for research because, for example, in our very big database, I come from Lombardy, a region of Italy with more than 10 million people. around Milan. And we have access to a database which includes all citizens. So we did a lot of work on adherence, because this is the best approach, because you cannot study adherence in trials, because in trials, patient knows to be under observation and doctors know to be under observation, and this alters the data on adherence. But from real life, we had a number of studies and showed that adherence is a big, non-adherence is a big phenomenon, and we could calculate adherence by the availability of drug prescription, and found that more than 60% of the patient over a follow-up of quite a few years had a prolonged period of treatment discontinuation. 3 months, 6 months, 9 months, and so on. But this, of course, can be studied, can be matter of research, but cannot be used for by the doctor at the patient bedside.
Professor Mancia, one of the very interesting aspects of this new guidelines, my Indian colleagues would agree with me, is the kind of resurgence of beta blockers. Now, it has been approved as a resurrection of beta blockers. So it has been approved as a monotherapy and also approved as any part of combination therapy. And we Indian physicians are very fond of beta blockers. Because we have
I'm glad to hear this, because I also thought that removing beta blockers was a mistake. I mean, we know that some conditions we don't give beta blockers, but looking at the available evidence, and you also there are so many specific conditions, and we are moving towards precision medicine, okay, tailoring treatment to individuals. And of course, the more specific conditions we know, I mean, we have, the greater is the chance to be able to tailor treatment. And I think what I forgot to mention in my presentation is that initial combination treatment, we recommend this in most patients, but there are some conditions in which you should continue to use initial monotherapy. For example, frail patients. For example, patients above 80 years of age. In these conditions, of course, the problem, we should avoid the risk that two drugs lower blood pressure too much, so we should start with one drug. And even patients with grade 1 hypertension, but with the blood pressure close to 140, we can start with one drug, because one drug could be enough to lower blood pressure below 140 and 130.
Thank you, sir. Sir, with permission,
any questions in the chat box?
With permission,
Can I
sir, with
have
permission
one
of,
question, Professor Mencia?
What?
Yeah.
Sorry?
Actually,
yes.
Yeah, definitely in this guidelines, we have the resurgence of the beta blocker. Again, we have the recommendation for the RDN, and we are Indians have higher percentage of the resistance hypertension patients. Maybe it is contributed by the poor compliance, poor lifestyle modifications, and poor education of our patients, but we have little bit higher incidence of the resistance hypertension. So what your opinion and experience of the RDN in these kind of population, and as we are intervention cardiologists, we are much awaited this therapy in India, and we are welcoming this. So what your take on that in the resistance hypertension?
I'm not sure I capture your question exactly. What is the effectiveness of beta blockers on
sir,
effectiveness of renal denervation therapy in resistant hypertension?
Renal denervation.
Yeah.
Well, can be an adjunctive therapy, because if you look at the data, 5 or 6 randomized clinical trials, very well done. The randomized trial which was done, the SHEM trial which was done, was not well done. I mean, it caused a lot of confusion. But these 5 or 6 trials, not only this, but I'm co-coordinator of the registry. More than 3,000 patients now followed for more than 3 years. And in this registry, you can see that the reduction of blood pressure caused by renal denervation persists for 3 years and is rather safe. So these are pluses. The minus is that the reduction in blood pressure by renal denervation is not a big one. It's few millimeters of mercury, 5, 6. ambulatory, which correspond to 8-9 office blood pressure, because as a mean, ambulatory blood pressure has a smaller value, a smaller reduction than office. But I mean, I do not think that renal denervation resolves the problem of resistant hypertension. It could be, while before it was not recommended by the European guidelines, it is now an option. It's correct to say it is an option, which can be presented to the patient with drugs fail.
Thank you, sir. Soumitra Kumar, sir, with your kind permission, we have some audience questions.
Sure.
With your permission, if we can just take it. And this would be something that we would have it interactive with each of the panelists as well as Professor Mancia. So the first question that has come from the audience is on the same perspective of beta blockers, as you rightfully put forth, sir. So considering the fact that beta blockers are now recommended in uncomplicated hypertension too, unlike previous guidelines where it was niched for hypertension with CAD or AF or hypertension with heart failure. So in the current Indian scenario, should we consider that, go back to old school medical teaching, maybe a young patient with a sympathetic overactivity coming with a high resting pulse rate, is this a right patient population maybe to consider for new generation beta blockers? Professor Soumitra Kumar, sir, over to you.
Yes, I think they can be used also for uncomplicated hypertension. Another consideration to be made is that beta blockers are a heterogeneous class. I mean, if you have cardioselectivity, this is an advantage. If you have another vasodilatation, this is also an advantage because it completely changes the hemodynamic pattern of the effect. That is, you have vasodilatation and no reduction in cardiac output. Preservation of cardiac output and therefore preservation of peripheral blood flow, such as skeletal muscle blood flow, is effective in avoiding fatigue and reduced ability to exercise. So you see that, pharmacology has progressed in these years, and some of the disadvantages of beta blockers can be dealt with.
Noted, sir.
Dr. Professor Mancia, do you think that by giving drugs like ACE inhibitors and angiotensin receptor blocker, also the heart rate comes down, in my experience, because when you are blocking renin-angiotensin system, it also has indirectly the effect on sympathetic nervous system also, because basically renin-angiotensin system is directly linked with sympathetic nervous system. So I think always the beta blocker is not that it reduces the heart rate. If you well control their blood pressures, I think their heart rate also comes down. That is what I have seen. So I think beta blockers, always in India, we say that beta blocker is required because our patient's heart rate is more. But I do not believe on that. I believe that giving drugs like calcium channel blockers and other drugs also can reduce the heart rate if you control their blood pressure very well.
Yeah, you're absolutely right that the renin-angiotensin system has an amplifying effect on sympathetic influences. We studied this in animals and men at the level of the heart with rather complicated invasive studies. So this is true. But if you look at the data available from trials, the effect on heart rate is barely visible, 1 or 2 beats, no more, on average. So I don't think that blockers of the renin-angiotensin system can deal with people having not only an increase in blood pressure, but also an increase in heart rate, for example, 80 beats per minute. This is another indication for beta blockers, by the way. There is evidence from my laboratory in Milan in which we measure sympathetic activity by sympathetic nerve traffic in humans, that above 80 beats per minute, you have a sympathetic activation. And so this is indication to lower heart rate above 80 beats per minute, and the best drugs to do this are beta blockers for sure. What we do not know, however, is how much this reduces cardiovascular events in addition to the reduction in blood pressure. There are no trials, only observational studies. And we do not have a target heart rate value. That is, we should reduce heart rate above 80 for sure, or probably not for sure, but how low we should go? 70, less than 70? This is not known. But the indication to reduce, to use beta blockers to reduce a heart rate in hypertensive patients when heart rate is above 80 beats per minute, I think it is supported by quite a few well-done observational studies.
Professor Mancia, talking of combinations, there was an interesting meta-analysis presented in this year's ESH comparing the various combinations. Now, ARB plus CCB combination came out to be the best, but ARB diuretic combination didn't fare so well. Do you believe in this? I mean, or it was a chance finding? So ARB, CCB being the best.
CCB, RB versus CCB.
ARB, CCB versus ARB diuretics. So how, I mean, that meta-analysis showed that ARB, CCB is the best in terms of efficiency and tolerance.
Well, if you look at, for example, the data from...
So pardon me, just to add on to that, a same audience question has come on the same light. How would you probably delineate which patient should receive an ARB plus a diuretic versus which patient an ARB plus a CCB?
Sure.
If you could throw more light on the same too.
This is an old question, and already in 2018, we decided not to make a discrimination. That is, to consider the combination of a RAS blocker and the CCB at the same level of a combination of RAS blocker and diuretic. And I think the data from ACCOMPLISH go in this direction. And this makes it is difficult to say which patient are better, do better with the combination of the diuretic and which patient do better when the combination includes a CCB. Theoretically, you would say a patient with dysmetabolic problems, okay, because CCBs are neutral in terms of lipid metabolism and glucose metabolism, whereas with diuretics, you do have some dyslipidemic effect and you have increase in insulin resistance in some patients. So theoretically, yes, but at the practical level, data which have analyzed these two combinations, and the best one is ACCOMPLISH because it was just organized, conducted for this. They didn't show any difference in cardiovascular events in favor of adding a CCB. Of course, I mean, I can still, do my practice considering mechanistic factor. This is something which I think is clear. Guidelines address diseases in general. Now, things at the individual patient level can be different. So if a doctor having a patient with dyslipidemia already, or metabolic syndrome, for example, and decides to give the preference to a RAS blocker plus a CCB, he cannot be accused of medical misconduct.
Thank you, sir. So one question which comes, I would just take on from what Professor Jariwala as well as Dr. Akhil just mentioned, some time back, that patients in India often tend to come directly to the ER with evidence of end organ damage, and it's retrospectively that one realizes and understands that the patient also had hypertension as one of the major risk factors. It's not uncommon to find a hypertensive encephalopathy wherein you detect hypertension as a root cause, or a patient with an MI, or so on and so forth, ultimately saying, oh, fine, the root cause was hypertension. So on the same end, some perspectives from renal disease, especially in the Indian scenario, some tips and tricks if you can suggest. when a patient comes with maybe to the hospital directly with evidence of anemia, stage 3B, and a resistant hypertension at that time, the question that comes to the clinician is, which came first? Was it the hen or the egg? So was it renal disease which caused the hypertension, or was it hypertension which caused the renal disease?
Actually, I will give an example of this. Very rightly you pointed out. Just last week we had a patient of type B aortic dissection, and he is only 46-year-old gentleman, and his blood pressure was almost like 230 millimeter of mercury when he came in emergency, and we found that he's having aortic dissection, and his creatinine was around 1.5, and we did his TEVAR, that is endovascular aortic repair, and in the hospital his creatinine started coming down, and we could discharge his by 0.9 was the creatinine, like normal creatinine. And today he came to me for follow-up, and I found that his creatinine is 2.1. And so I consulted my nephrologist. Nephrologist said, let us see whether aortic dissection is causing any renal compromise. So we got his renal Doppler done, and the renal Doppler was showing normal blood flow to kidneys. And what we found is there is a grade 1 parenchymal changes. So what I contemplated from this is that he may be having a CKD before and chronic kidney disease, which led to the high blood pressure in him, leading to a complication of aortic dissection. And because maybe when he was in the hospital, we gave him a lot of blood and lot of IV fluids. So that must have normalized his, because of good hydrations, his creatinine came normal. And again, he has gone back to the renal dysfunction. That is what we felt both our, because there are grade 1 renal parenchymal changes are there. So this is very common scenario. What you spoke exactly is a similar situation I faced recently. So we were wondering whether it was blood pressure caused it, or whether he was already having any kidney disease.
Thank you, sir. Professor Mansia, tips and tricks from your end in such a scenario.
I don't have any comment on this, except for the fact, because of course, what comes first is the story of the hen and the egg, in a way, you know. But what really, I can tell you that when we were preparing the text of the guidelines over the last 6 months, the nephrologists in the task force committee, what was written on hypertension is the second largest cause of renal failure in the world. And the nephrologist wanted to cancel the word the second. Because if you look at the number of hypertensive patients, and you look at the absolute number of renal failures caused by hypertension, probably they are correct. I mean, this is the number 1 cause. And from a practical point of view, it doesn't matter, because at any rate, blood pressure has to be reduced when it is elevated. But the kidney story is one of the most complicated story I found in terms of deciding which is the target blood pressure for treatment. I mean, some of you are expert nephrologists from the discussion. I think you are. And you know, if you look at the literature, I mean, it's not easy to come up with a univocal decision or recommendation about which is the best the best value to consider for treatment.
Professor
in
Mansia,
2018, for example, we selected between 130 and 140, and now we're gone to below 130. But whether this applies to both patients with proteinuria and patients without proteinuria is not so clear, in my opinion.
Professor Mansia, you also commented that reducing urinary albumin creatinine ratio means that you are doing a good job.
Yeah.
Is it equated with better prognosis for the patient? reducing proteinuria?
Maybe I'm biased, you see, because I know in the United States they have non-univocal data on this. And but, for example, in On-Target and Transcend, we had a very nice, huge number of patients, 30,000 patients, and followed for more than 5 years. And it was clear that patients in whom, during treatment, there was an increased proteinuria, they develop more cardiovascular and renal events compared to those who had no change or a reduction in proteinuria. And I think this is good evidence, and not the only one, because there are other studies sharing the same conclusion. So I would consider this an event with evidence that if you improve this target organ damage, it is this is beneficial.
Dr. Parthasarathy, do you have time or
Just
any other questions?
One more last question, sir, before we wind up.
Okay, last question. I have to go back.
Yes, sir. So you showed a very wonderful slide on the score risk factor, the score risk for European patients, which is validated for Europeans. But you also showed in the same slide something that is probably very relevant clinically for Indians, wherein you would include male sex, age, the level of systolic blood pressure, whether the patient is a smoker or not, and non-HDL cholesterol, which we find very interesting because traditionally we are a country which has a very huge atherogenic dyslipidemia burden. So a huge non-HDL cholesterol there too. Sir, a question to you as well as to our Indian panelists where we don't have such validated scores in the Indian setup. So should this just be used very typically as a checklist in the history when looking at risk factors, and especially wherein we try to probably understand the grade as well as the stage of hypertension?
This course trial, of course, the merit is that he collected data from more than 200,000 patients from all over Europe, and then he divided into regional data. There is higher risk people in Northern Europe and lower risk people in Mediterranean country, and then they were even more complex. And there are description about the fact that you should recalibrate the regional data. So it's a bit complicated based on the national case. And this should be, of course, the case. Suppose that you want to try to have score in India, you should recalibrate according to the Indian situation, which is completely different from the European, also in terms of age. But score would not be good for India because the calculations are only done above 40 years of age, and we mentioned this in the guidelines. So I'm glad that this was an appropriate comment. 40 years of age is not good for Europe either, but for India it would be awful. I mean, it's useless. Then, of course, the number of risk factors included in the algorithm has to be limited because otherwise you cannot do the calculation. So all the others I showed, all the other risk factors I showed are not included in the calculation, but nevertheless, they should, a doctor should have a list of them and be sure that he gets the information from the patient. Then the information becomes part of the general judgment the doctor develops.
Thank you so much, sir. Dr. Soumitra Kumar, sir, for your last comments on the same.
That was excellent, elaborate in a discussion on so many aspects of hypertension management. It was simply absolutely enjoyable and extremely knowledgeable session. We learned a lot, and I interacted on many points that are relevant to patients in India, like starting at the young age, the resurrection of beta blockers, and then the various combinations that we use. So all in all, I mean, it was a very session for all of us. And thank you, Professor Mansia, for spending 90 very useful minutes with us. It was absolutely enjoyable and thoroughly, absorbing session, if I can call it so. So thank you very much. And thank you, my colleagues, Dr. Pankaj and Professor Akhil and the team of Macleod. So over to you, Dr. Parth Sarathi.
Thank you, sir. We at Macleod's Pharmaceuticals take the opportunity to thank each and every one of you. A special thanks to our esteemed moderator, Professor Soumitra Kumar sir. Special thanks also to Professor Giuseppe Mancia for taking your valuable time to enlighten a huge Indian audience on the ESH guidelines and takeaways from the Indian practice. We also extend our sincere gratitude and thanks to our esteemed panelists, Dr. Pankaj Jariwala and Dr. Akhil Sharma, who very wonderfully put forth practice, clinical pearls, and challenges from the Indian clinical setup. Dear audience who are attending this webinar at this time on a weekday, so thank you very much for actually attending and having your takeaways and learnings too. And we are very sure that takeaways and learnings that you've taken from this webinar would ultimately empower you in your clinical practice and ultimately better your patient outcomes. Last but not the least, we also thank our technology partners, Club Class and Mr. Raghu for aiding in the very smooth streaming of this webinar. Thank you one and all. Have a great day. Good night.
Thank
you.
Thank you to
Good
all.
night.
Thank you.
Thank
Good
you.
night.
Good night.
Thank you, Professor Mancia. It was an honor to host you.
Thank you. It was a pleasure for me too to have this very interesting discussion.